Good afternoon, doctors. This is our answer to the case 67 of on cghsclinics.com. So the message that this patient gives you is look at the face of the patient. This will give you a clue to important diagnosis. We saw previously one case or two cases of mixed edema which were very obvious when you look at the face of the patient. Similarly, in our patient, this patient, we can in this patient who is referred to me for uncontrolled diabetes mellitus had a very characteristic face, and he had a frontal bossing, enlarged nose, lips, and also had a characteristic enlargement of fingers, which difficult to appreciate on this picture because you need a similar age and height patient to compare the size of the fingers. But similarly, we can also suspect cushigoid face in our OPD if similar presentation happens. The manifestations of acromegaly can remain undiagnosed for almost 10 years. As I said, there could be frontal bossing, mandibular enlargement with prognathism, and widened space between the lower incisor teeth. There could be hyperhidrosis and a characteristic deep and hollow sounding voice, which our patient had sometime in the during the course. I will definitely record his voice and make it available to you. He retrospectively agreed that his shoe size was increasing and also his finger size was increasing. Other presentations could be arthropathy, kyphosis, carpal tunnel syndrome, and proximal muscle weakness. 25% of the patients of acromegaly develop diabetes, and it remains uncontrolled with most of the drugs. Even the GI gets involved. There could be increased incidence of colonic polyps and mortality because of the colonic malignancy. Our patient did not have any GI complaints. Most important is these patients are at high risk of heart disease, cardiomyopathy, arrhythmias, and left ventricular hypertrophy. So you need to screen their heart very well. They also can present with obstructive sleep apnea, which may persist even after correction of acromegaly. So how do you confirm the diagnosis of acromegaly? The best screening test is the age and sex matched serum IGF-1 level. In our patient, it was almost twice the upper limit of normal, 401 nanogram. Normal was upper limit was 252. The single random growth hormone level is not at all diagnostic. You need to show that it doesn't get suppressed with oral glucose tolerance test. So our patient's baseline growth hormone was 23.4, which actually increased to 34.8 after 1 hour of glucose instead of getting suppressed. Similarly, prolactin can also be increased, but in our patient it was normal. Please ask for MRI pituitary and not the brain, because it can miss. The technician who is not alert on the possibility of acromegaly may just take normal cuts and give you a normal MRI brain. This is what exactly happened in our patient. So when I talked to the endocrinologist, she specifically told to take special cuts for pituitary, which later on confirmed that there was a small microadenoma. So this is a snapshot from the patient's investigation table. The growth hormone at 1 hour 34.8. The first normal MRI was normal, brain was normal. but the repeat scan with special pituitary cuts showed a microadenoma in the left half of the pituitary. So now the patient is planning for further treatment, but he's currently on holidays. So once he gets back, he will contact us and we'll let you know the update on these patients. So thank you very much for watching our telecast on acromegaly and the answer of case 67 on cghsclinics.com. I hope the live telecast was up to the mark. Let's see. Thank you. Bye bye.